is my sarees lying?
Okay, shall we start?
Yeah, please.
It's certain.
Good evening and warm greetings to all the postgraduate students, esteemed faculty members, and respected dignitaries who have joined us today for the ISA National online PG class. These classes are conducted every Monday at 6:30 p.m. and topics of academic interest are discussed for the PG students by eminent faculty members. The topic for today's discussion is anesthesia for a patient with obstructive jaundice posted for Whipple's procedure. I am Dr. Priyakshi Bora, currently working as senior resident at AIMS Guwahati in the Department of Anesthesia. I will be the screen coordinator for today. Before we begin, let us invoke the blessings of Goddess Saraswati with the Saraswati Vandana. I will now request Dr. Sukhminder Bajwa sir, Honorary Secretary, ISA National, to address the audience. Over to you, sir.
Thank you, Dr. Priyakshi. Today we have a very important class. I think almost on the same line we had a class previously in the pediatric age group. Now it's in the adult patient where we had a obstructive jaundice. That means the liver is almost a compromised state and landing up for a Whipple's procedure. I think many of the major centers in our country, many of the medical colleges, this procedure is commonly performed. May not be that much, in frequency, but this is a procedure where the real skills, knowledge, patience, and so many things of the anesthesiologists are tested, right from the pre-operative to the post-operative care area. Especially in the patient with this diseases, the hepatic tissue is compromised to a variable degree. It's very difficult to decide even the pre-operative planning also, the types of drug being used, the how much dosage, how to titrate it, and so many things are there just to prevent a complication because majority of the drugs are going to be metabolized by the liver. The hepatic, whether it's a oxidation reaction or reduction reaction, every reaction is compromised in these patients. So the basic enzymatic functions are also depressed to a large extent, and the conjugation process then having effect on the kidney, the renal tissue, the involvement of the multi-organs in these type of patient is a very big challenge. Intraoperatively, it's not an easy job if you are going to get this patient operated with a compromised body immunity, with a compromised bodily functions. This is a huge challenge when you manage these patients, and the surgery duration is also a very long duration. You have to have, I think, a good post anesthesia care unit, maybe the ICU, where you can always monitor and treat the patient post operatively. And also, there are many other challenges, I think, when the comorbidities are associated. I think they will come for discussion. And for that, we have a very experienced faculty with Mariam Thomas Koshi madam and our Usha Shenoy madam. They are this, especially from Thrissur. I have been to Thrissur once. I know they are functioning the Jubilee Mission Hospital. It's one of the famous hospital and one of the most important, my memories tell me about the functioning of this hospital. It is one of the best in the country. So I think today we will have a very good class. Madam Usha Shanoy is just asking if we are going to live to the expectation. No, ma'am, you will, because we have listened, heard a lot about this hospital, and they are ready with the team also. So over to you, Priyakshi, to take it forward.
Thank you, sir. I will now request my co-screen coordinator, Dr. Ayushi Soni, ma'am, to introduce the faculty members of today's session. Over to you, ma'am.
Thank you, Dr. Piakshi. Good evening, everyone. Myself, Dr. Ayushi Soni, currently working as Assistant Professor, Department of Anesthesiology at Sri Aurobindo Institute of Medical Science, Indore. I am the screen coordinator for today's session. It is my proud privilege to introduce faculty for today's class. So our first faculty is Dr. Mariam Kaushi Thomas, ma'am, Professor, Head of Department of Anesthesiology at Jubilee Mission Medical College and Research Institute, Thrissur, Kerala. She has teaching experience of 34 years and her specialty of interest are pediatric anesthesia, orthopedic anesthesia, and USG guided regional anesthesia. She is a chief anesthesiologist in Ismail trainee program and she has 12 publications. And our second faculty is Dr. Usha Shanaya, ma'am, Professor, Department of Anesthesiology at Jubilee Mission Medical College and Research Institute, Thrissur, Kerala. She has teaching experience of 25 years and her specialty of interest are focused, ultrasound guided regional anesthesia, resuscitation, obstetric and pediatric anesthesia. She is AHA certified instructor for BLS ACLS training, trainer for the obstetric RAT training program, adjunct faculty at Jubilee Research Institute, primary investigator for an ICMR project, and has fellowship in pediatric anesthesia from Singapore. And she is awarded with Best Poster Presentation Award at ASPA Coaching 2024. And she has 11 publications and 2 chapters. Now, before proceeding forward, I would like to inform you all rules of this session. First of all, the audience please keep themselves muted and video off, and the audience will be muted for the duration of talk, and you can type your queries in the chat box. Now, I would like to welcome our faculties. Ma'am, please, you may take the session and introduce your PG students. Thank you, ma'am.
Good evening, esteemed colleagues, respected organizers, and dear postgraduates. On behalf of my co-moderator, Dr. Usha Shenoy, and our team from Jubilee Mission Medical College, I extend our sincere gratitude to the organizers for this invitation. It's indeed a privilege to contribute to this National Academic Forum. Our focus today is on a complex scenario in perioperative care. The patient with obstructive jaundice undergoing a Whipple's procedure. As you all know, this condition demands a deep understanding of its pathophysiology as it has profound systemic effects on the cardiovascular, renal, hematological, and immune domains, which require meticulous anesthetic planning and constant vigilance. With this in mind, we have set 3 key roles for our session. First is to formulate a comprehensive preoperative optimization to develop intraoperative anesthetic and hemodynamic management plans and to review the management of common postoperative complications. Today, we are joined by 2 of our second-year postgraduates who will be actively contributing, Dr. Anjali Arvind and Dr. Anup John. Finally, as a courtesy to our postgraduate students who are watching us, I encourage you to review the past discussions of this forum regarding obstructive jaundice. Given the elaborate nature of this topic and our time constraints, as we have deliberately built upon those foundations to avoid repetition and bring new insights to the fore. Let's begin today with Dr. Anjali, who will walk us through the critical elements of preoperative assessment. Over to you, Anjali.
Respected faculty and colleagues, good evening. So today we are presenting the case of obstructive jaundice posted for Whipple's procedure. So our is a 65-year-old female who is a housewife from Thrissur, and her presenting complaints are loss of appetite and weight since 3 months, multiple episodes of vomiting since 1 month, yellow discoloration of eye and high colored urine since 10 days. History of presenting as patient was apparently normal 3 months back, and then she developed loss of appetite and feeling of weakness for the past 3 months. She also gives history of weight loss of approximately 6 kg over this period. Then she gives history of vomiting for the past 1 month, which was intermittent in nature, preceded by upper abdominal pain, non-bilious and non-foul smelling nature, and there was no reflex of or any time association. And over the last 10 days, patient noticed yellowish discoloration of eyes, which was insidious in onset, gradually progressive and associated with generalized itching. She also gives history of high-colored gray-colored stools, which was not bulky for this period. And there was no history of cough, excess palpitation, symptom or chest pain, and any history suggestive of vitamin malabsorption like dehydration or weight, and no history of suggestive of deranged coagulation. Gingival and history suggestive of renal or urea, and no history suggestive of cystic cholangitis like and no history of graduate or blood transfusion. And past history, there is no history of jaundice, drug allergy, hepatobiliary surgical infection, or neoadjuvant chemotherapy. And in personal history, the patient gives a history of sleep disturbances due to bowel and bladder, not habituated to smoking, drinking, and no history of substance abuse. And from family history of jaundice.
Coming to general examination, patient is moderately built and with a weight of 53 kg, height of 158 cm, and a BMI of 21.2. Her mid-arm muscle circumference was 20 centimeters. She was conscious, oriented to time, place, and person. Her vital showed heart rate of 60 beats per minute, blood pressure 130/80 millimeters of mercury, measured in the left arm, supine position, respiratory rate of 18 breaths per minute, thoracoabdomen, and she was afebrile. On general examination, icterus pallor was present, scratch marks were present all over the body, and no pedal-edema, cyanosis, palpable liver, and no index features of liver decompensation. In airway assessment, mouth opening was more than 3 fingers, no restriction of neck movements, malembetic class was grade 2, and upper bite, lip bite test was class 1. Systemic examination, abdomen, inspection, flat abdomen, scratch marks, and no masses or scars visible. On palpation, firm liver edge below the right costal margin, and on percussion, a tympanic node. Liver dullness was obtained at the 5th intercostal space, mid-clavicular line, and on auscultation, normal bowel sounds were heard and no. Cardiovascular system works within normal limits, and METS score was more than 4. And in respiratory system, normal vesicular breath sounds were heard with a room saturation of 98%, and there was no focal neurological episodes. Into the summary of the patient, a 65-year-old patient with history of painless progressive jaundice associated with loss of weight and appetite, suggestive of obstructive jaundice, came for further evaluation and management.
Thank you, Anjali and Anu. Now, from your history, what features support the diagnosis of obstructive jaundice?
From the history, yellowish discoloration of eyes, high-colored urine, clay-colored stools, generalized itching or pruritus, loss of weight and loss of appetite, suggestive of obstructive jaundice.
Now, Anu, what do you think is the cause of this obstruction?
Probably a malignancy, because from the history, a painless progressive jaundice with unintentional significant weight loss, loss of appetite, and features suggestive of GI obstruction, such as early satiety, indicate a malignant etiology.
So, why is this relevant to us?
And the diagnosis of malignancy is important because malignancy alone is an independent predictor of poor outcome of obstructive patients, and hence it is of importance.
Now, Anjali, from this history, what are the red flags?
In our patient, madam, age, possibility of malignancy, and sarcopenia are the red flags. But luckily, she doesn't have other high-risk factors like associated cardiovascular and pulmonary disease or comorbidities, hypertension, malignancy, and poor glycemic index, and no features suggestive of presenting cholangitis like fever with chills, and no features suggestive of renal dysfunction like uremia and aortic.
So, why did you mention neoadjuvant chemotherapy? Was there any particular reason for this? Anu, will you take this?
Madam, in our patient, neoadjuvant chemotherapy was not done. Neoadjuvant chemotherapy usually improves the surgical outcome by shrinking the tumor in borderline resectability. So, but these drugs can induce neutropenia, thrombocytopenia, direct cardiotoxicity, hepatotoxicity, as well as acute kidney injury. Also, surgery may be technically more difficult in these patients because there may be tissue fibrosis, which can prolong the duration of the surgery and increase the risk of bleeding. So, also we must anticipate a difficult IV access in these patients because of the presence of TBADs like chemo. And also, chemotherapy in these patients impair their nutrition. However, since chemotherapy usually lasts for around 2 to 6 weeks, it gives us an opportunity to identify these patients for simultaneous rehabilitation.
We'll take our first break for a quiz. Our first task is match the following. On the right, we have some common causes of hyperbilirubinemia. On the left, sorry, and on the right, we have their anesthetic implications. Our task now is to match the columns. So please match the alphabet with the number. Your time starts now. Please use the chat box to give your answers.
The audience is encouraged to type their answers in the chat box.
Priyakshi, Dr.
Yes,
Priyakshi,
ma'am.
read the question. Read on the left and the right side. What is there?
Ma'am, I'll repeat the question.
Yes.
I can do it if you want.
Yeah.
You want me?
Yeah, ma'am.
On the left side, you have hemolytic anemia, acute viral hepatitis, and bile duct obstruction. On the right side, the first choice is to delay elective surgery. The second choice is serious renal and effects and kernicterus. And the third choice is anemia, pigment nephropathy, and AKI.
Ma'am, we have received few answers. Ajay and Sneha and Ashima has also typed A for 3, B for 1, and C for 2, ma'am. Even Anisha has typed that, ma'am. Priyanka also, and Muthu Kumar also, ma'am. A3, B1, and C2, ma'am. All of them.
Many more answers have come up.
Yes, ma'am. Usha Kumari also, Kavya also, and even Jasleen have answered, ma'am.
312. 312.
Yes, ma'am. 312. Swapnil also.
Yeah. Is that right, ma'am?
Yeah, so we are off to a good start. Fairly straightforward question here. Can we discuss the answer? Or do we wait for some more time?
No, ma'am. You please discuss.
Okay, so hemolytic anemia, like we all know, the main implication for us is anemia per se. And they can also have pigment nephropathy and go into AKI. So as anesthesiologists, we are likely to encounter this in, say, patients with sickle cell disease or a HELP syndrome which has gone bad. Acute viral hepatitis or any acute active hepatitis is a contraindication for elective surgery because we are worried for it will exacerbate the liver injury. And we also have concerns and with universal precautions are also relevant here. With bile duct obstruction, elective surgery is almost always necessary to relieve the obstruction. But what is different here when you compare bile duct obstruction and hepatitis is the possibility of the pathology affecting the heart and the kidney.
So what exactly is the effect on the heart? Or what is this terminology called jaundiced heart? Anjali?
Hepatic cardiomyopathy in patients with obstructive jaundice is termed as jaundiced heart. So in patients with obstructive jaundice, there will be elevated level of bile salts and bile acids. So it will directly affect the SAO and causes bradycardia, whereas the bile has a negative chronotropic effect, impairing the contractility of the heart, and also the receptor decrease the beta receptor density and responsiveness can impair the left ventricular function in these patients.
So what is the effect? The next pathophysiology is the effect on the PVR. So what is the exact effect in obstructive jaundice on peripheral vascular resistance or vascular reactivity?
In patients with obstructive jaundice, peripheral vascular resistance is reduced due to a combination of many factors. Firstly, vasodilation occurs due to increased circulating levels of bile acids as well as endotoxins, endogenous hormones, as well as there are accumulation of vasodilatory substances such as bradykinin, substance P. Also, there is a functional impairment in the alpha-1 receptors, resulting in decreased responsiveness to the vasopressors.
So what are the implications of this?
Madam, we calculate a prepare score based on the prepare score, which is a pre-operative pancreatic resection score used mainly by the surgeons to assess the surgical complications. The prepare score assigns a score of 2 points for any systolic blood pressure which lies outside the range of 110 to 130 millimeters of mercury. So clinically, if a patient has obstructive jaundice and his blood pressure is less than 110 millimeters of mercury, it suggests that the patient may need use of inotropic vasopressors intraoperatively. And in patients with chronic hypertension who are on anti-hypertensive drugs, a reduction in the need for drugs indicate that the patient's systemic vascular resistance is decreasing. And the anesthetic implication is that usually we can anticipate a vasodilatation or intraoperative hypotension in these patients. So while using anesthetic agents, which usually have a cardiodepressant effect, we may experience an exaggerated hypotensive response. Also, so that we should always maintain euvolemia or normal volemia in these patients. And also, since the receptors are defective, the patient may need a higher dose of vasopressors intraoperatively. And in patients with who are resistant to the catecholamine pressors, then we may need to use a direct acting agents like vasopressin or terlipressin in these patients.
See, most of these patients with obstructive jaundice looks puffy and usually edematous, but all the same, we treat them as though they are volume depleted. Why is it so?
So in patients with obstructive jaundice, the central volume depletion, madam, is the mechanism are impaired renin angiotensin system, decreased thirst, and decreased intake due to anorexia and fatigue, and the diuretic and natriuretic effect of bile salts and elevated levels of ANP and BNP. So there will be a decrease in the effective circulating volume, even though the total body volume is more in patients with hypoalbuminia, like and ascites.
So, would you like to sum up? What is the effect on the cardiovascular system?
Anjali, can I ask a question before that? If your patient has a heart rate, say around 45, will you be concerned, or say around 90? Are you worried about anything particular? You mentioned about bradycardia.
Yes, madam. The prepare score used to predict the surgical outcome gives a score of 2 for any heart rate value outside the range of 50 to 80. So a heart rate of less than 50 in patients with obstructive jaundice suggests an elevated level of bilirubin and bile acids. So I am concerned.
So what about a heart rate of 90? You're okay with that?
In patients with a heart rate more than 90, we need a prompt evaluation for yes, madam. Patients with severe obstructive jaundice, we need a prompt evaluation for heart failure, sepsis, and anemia.
Okay.
Thank you. Would you sum up on the effect on the cardiovascular system?
Yes, madam. The pathophysiological effects on cardiovascular system and decreasing the PVR. The patients are prone to hemodynamic instability because of the decrease in preload, heart rate, contractility, and afterload. So we need a pre-op thorough evaluation of the cardiac status and also pre-op volume status assessment and optimization. And this can also predispose the patient to renal injury.
Anu, so she has explained the effect on the cardiovascular system. Will you go on to the effect on the renal system, please?
Acute kidney injury and renal dysfunction are commonly seen in patients with obstructive jaundice. So this cause can be attributed mainly to two factors. It may be due to pre-renal cause or maybe due to a renal pathology. So in pre-renal cause, they may be due to a decrease in the renal blood volume or a reduced blood volume, circulating blood volume, and also if there is any vasoconstriction occurring within the renal vessels. And in coming to the factors which may cause a reduce in renal or a total blood volume, Anjali has previously mentioned that there's already a decrease in the circulating blood volume. Along with it, when our anesthetic agents may cause hypotension, and also the cardiac, as mentioned above, the cardiovascular system is also impaired, and the patient is already fasting, and there may be an intraoperative bleeding, and all these factors may contribute to a reduced blood volume in these patients. And also, there may be vasoconstriction occurring due to there is increased production of thromboxane, which causes vasoconstriction and a reduction in GFR. Also, usually the kidneys compensate for any decrease in the cardiac output, but here the autoregulatory mechanisms of the kidneys are impaired, and hence they cannot completely compensate for a fall in the cardiac output. So all these factors can contribute to the pre-renal cause of acute kidney injury. Coming to the renal cause, mostly there may be bile cars which can damage the renal tubules, and any tubular damage makes the tubules resistant to many hormones, especially antidiuretic hormone. Antidiuretic hormone usually causes natriuresis as well as diuresis, and all these factors together can contribute acute kidney injury in patients with obstructive jaundice.
So would you like to evaluate the function of the kidney in all these patients pre-op?
Yes, madam. We should promptly evaluate the renal function test in these patients pre-operatively because of the above mentioned factors.
Is there any cutoff value you are concerned, you are aware of, where your problems are more likely to happen?
Okay, madam. Our creatinine levels pre-operatively should be less than 1.3. If it is more than 1.3, it is an indicator of poor prognosis or attack.
Okay. What are your anesthetic implications of this then? What are the implications of this renal pathology for your management?
First of all, we should maintain euvolemia throughout the procedure and avoid any insult to the blood supply to the kidneys. we should avoid any intraoperative hemodynamic instability. We should avoid using drugs which are nephrotoxic, such as NSAIDs, aminoglycosides, and always we should monitor the urine count and try to maintain a urine more than 0.5 ml per kilogram per hour, and also assess the serum electrolytes intraoperatively as needed.
So why are you so concerned that if the patient develops a kidney injury, what does it do to your outcome? Are you aware of any particular connection with bad outcome?
Madam, if the patient develops an acute kidney injury intraoperatively, then the survival chance or the increased risk of perioperative mortality and morbidity increases in these patients. So it is very important to maintain the kidney functions intraoperatively and avoid any circulation.
Good job. Now we move on to our next question to give them a break. And this time it's a true-false. There are 3 statements here. The first statement is, all the 3 statements are regarding post-hepatic jaundice. The first statement is that obstructive jaundice results in defective synthesis of vitamin K-dependent coagulation factors due to impaired absorption of vitamin K. The second statement states that INR not corrected within 24 hours of vitamin K therapy points to hepatocellular synthetic dysfunction in addition to biliary obstruction. And the third statement says elevated unconjugated or indirect bilirubin is unlikely even in severe obstructive jaundice. So this is true, false. Please type in your answers in the chat box. What is this?
Ma'am, Dr. Preeti and Dr. Kiranjeet have replied as option number 3. Dr. Mohan, Dr. Ajay, Dr. Kavya, and Dr. Vismaya. Dr. Ashima also, and Dr. Sneha has option 3. Dr. Swapnil also has option 3 as false statement.
Shall we move on and discuss or wait?
Ma'am, please go ahead.
Okay. So it looks like we have a lot of very knowledgeable postgraduates here. So this slide was mainly to highlight one point, that is, in severe obstructive jaundice, there can be hepatocellular damage due to back pressure, and that should be suspected when you have elevated unconjugated bilirubin, or if the INR is not getting corrected with vitamin K therapy. So that means there's a synthetic dysfunction in the liver too. So these are not good signs when you're dealing with a patient with obstructive jaundice.
So now we go on to the next question. Now, in obstructive jaundice, what is the mechanism of gut-derived sepsis? And does your patient have this?
The systemic infection that originates from the gastrointestinal tract due to bacterial translocation across a defective mucosal barrier is termed as gut-derived sepsis. So normally, the bile salts plays a very important role in maintaining the gut sterility by inhibiting the bacterial proliferation and enhancing their clearance from the gut. So in patients with obstructive jaundice, the bile salts does not reach the intestine, and thus the antimicrobial property is lost. So there will be small intestinal bacterial overgrowth of epithelial flora, and they causes mucosal barriers dysfunction and increases the permeability. This causes bacterial translocation and into the portal circulation, and from there they reaches the liver. And inside the liver, the increased concentration of intrahepatic bile acids and also the defective Kupffer cells decreases their clearance, causing these bacteria and toxin to reach the systemic circulation and causing the systemic inflammatory response syndrome and sepsis. And also, the defective tone of the sphincter of OD can cause retrograde migration of this bacteria and toxins, and thus causing ascending cholangitis. And in my patient,
any other factor apart from this in obstructive jaundice which predisposes them to infections?
Yes, madam. In patients with obstructive jaundice, their cell-mediated is also disrupted, predisposing them to infection and sepsis.
Good. So what are the implications?
As these patients are prone for sepsis and infection, antibiotic prophylaxis is mandatory, and this can also cause intraoperative hypertension. So, fluid monitoring and close monitoring of the organ dysfunction is important, and we have to maintain normovolemia throughout the procedure. And we can consider biliary drainage if the patient is symptomatic, like features of ascending cholangitis present and severe hypertension.
So when would you say features of ascending cholangitis? What do you mean by features of ascending cholangitis?
When the patient is having fever with chills,
Pain,
pain,
right? Okay. Oh, there's a history of any
ERCP.
instrumentation? ERCP?
Yes, ma'am.
So you mentioned something about sarcopenia. What is can you elaborate on it or on this terminology?
Sarcopenia refers to the loss of skeletal muscle mass, strength, as well as the function. It may occur due to aging, chronic illness, or in malignancy. When coming to malignancy, there is a cancer cachexia, which means muscle mass loss can occur, but with or without fat loss. It is relevant because it is a poor indicator of poor outcome. It's a poor indicator of surgical outcome in patients.
Poor indicator or a good indicator?
A decrease, a sarcopenia indicates a poor surgical outcome.
Okay. Okay. Yeah.
So to assess sarcopenia, we can, with the help of CT scan, we can assess the area of the psoas muscle at the level of L3 vertebra. As shown in the image, first image shows a normal patient where we have highlighted the psoas muscle. It's at the level of L3 vertebra. And in figure B, there is a decrease in the muscle mass of area under the psoas muscle. And this indicates a patient who has sarcopenia.
So the Anjali, why are these patients usually malnourished? You said your patient was malnourished. What is the significance?
So malnutrition is seen in around 40 to 70% of patients with obstructive jaundice, madam. The causes can be fat malabsorption due to lack of bile salts and cancer-related catabolism causing protein breakdown, vomiting, limiting the intake, and also anorexia and indigestion and diarrhea, so pancreatic insufficiency. And if patient is taking neoadjuvant chemotherapy, it can also cause vomiting and mucositis.
So how will this malnutrition affect recovery and anesthesia care?
So impaired immunity in these patients can increase the risk of infection and sepsis, and decrease the skeletal and respiratory muscle functions can cause decrease in the pulmonary reserve, and delayed wound healing can affect the postoperative outcome.
How will you assess nutritional status in these patients?
From the symptoms like anorexia, early satiety, vomiting, altered food intake, it prompts us to have a nutritional assessment of the patient. Commonly used screening tools for nutritional assessment include MUST, which is Malnutrition Universal Screening, NRS 2002, which is a nutritional risk screen. Also, if there is a subjective global assessment. And all these include anthropometric measurements such as weight loss, which is an unintentional weight loss of more than 10 weight loss of more than 10% occurring over a period of 6 months, which indicates severe malnutrition. Also, body mass index is an indicator, and the mid-arm muscle circumference are usually used. To assess the functional strength in these patients, we use hand grip strength test. And for biochemically, we can assess using the values of serum albumin, prealbumin, hemoglobin, as well as glycemic control. And from the CT or imaging modalities, CT can detect the presence of sarcopenia.
Anjali, tell me, how can you improve the nutrition in these patients?
So preoperative nutrition optimization is crucial in this patient, madam. This can
तो
be
पूरा
achieved.
बस के निकल गया वो हम तो घूमते घूमते निकले
This can be achieved by preoperative dietary counseling, oral nutrition supplementation like low fat, high carb, and high protein diet, and enteral nutrition like nasogenital food can be considered if gastric emptying is delayed, and total parental nutrition can be considered if there is severe malnutrition and patient is not tolerating orally. But this has to be started at least 5 to 7 days prior to surgery and has to be post-op. So my goal is to maintain a total serum albumin of more than 30 gram per liter or protein of more than 60 gram per liter.
Yes, good, good. So we back to break time. This is again two true-false statements. The first is regarding BMI. Is the statement true or false? A patient can have a normal or high BMI but still be sarcopenic. The second statement says that liver function test derangements always correlate with the severity of the liver disease. Please enter your answers on the chat box.
Ma'am, Dr. Kiranjit, Dr. Priyanka, Dr. Kavya, Dr. Anisha, and Dr. Preeti have said that the first one is true and the second statement is false, ma'am. I'm Dr. Spurti, Dr. Mohan, Dr. Sneha also, ma'am. First statement true, next statement false, ma'am.
Shall we discuss the answer? Should we wait? Can we go ahead?
Yeah, ma'am, please go ahead.
Yes, ma'am.
Okay. So yeah, again, the RPGs seem to know what is happening here. So this first statement is true because BMI actually does not differentiate between fat mass and muscle mass. So it cannot identify. There's a concept called sarcopenic obesity, which carries a high risk. And this is relevant to us because we know that obesity per se is a risk factor for CA pancreas. And we may miss the sarcopenia unless we look for it with functional tests in these patients. And coming to the next statement, this is a major limitation of liver function test for a couple of reasons. First, of course, is that the liver has a very large physiological reserve. So when you see a decrease in the synthetic function, it's very late in the process. It's not an early sign, it's a late sign. And secondly, the liver enzymes which we detect and the raised liver enzymes usually are detected when the liver cell is injured. And that means you must have sufficient working functional liver cells. Now, in diseases like cirrhosis or NAFLD, the functional cell mass is reduced because they are either replaced by fibrosis or fat. So you might have actually normal liver enzymes despite severe liver failure. And we need to be aware of these limitations.
Now that you know the history, what next? How will you evaluate this patient further?
From the investigations shown in the slide, the patient has anemia, total bilirubin level is elevated, albumin level is slightly on the side, alkaline phosphatase is elevated. She has a mild coagulopathy with a slightly deranged INR values. And the CA marker, CA19.9 is elevated, showing a 60. Kidney function or RFT are within normal. And echo shows a mild left ventricular dysfunction, which may normally occur in elderly patients. Imaging modalities such as USG as well as CT show a mild obstruction or a biliary obstruction. And endoscopy also revealed a periambulary.
So why do you say this is obstructive jaundice? Altogether, whatever in the history and in the investigations which suggest obstruction.
the symptoms of the patient. This pain is progressive jaundice, high colored urine, serum, clay colored stools. And from the investigations, we can observe that there is an increase in bilirubin. And all these factors, along with the imaging modalities, point to a obstructive
Enzyme,
pathology.
enzyme test, do you want to comment on the enzyme levels? Is there any clue from there?
Yes, madam. From the liver enzymes, we can actually identify whether it is a hepatocellular injury or whether it is an obstructive pathology. Usually, we take the ALT by ALP ratio, and if it is less than 2, it is suggestive of obstructive jaundice. Whereas in hepatocellular injury, the ALT to AP ratio, that is alkaline phosphatase ratio, will be more than 5, which is suggests a hepatocellular injury.
Now, what is the clinical importance of estimating hemoglobin concentration in these patients?
So anemia is common in patients with obstructive jaundice because of malignancy, malnutrition, and diabetes, and chronicity of the disease. So a hematocrit value of less than 30% is an independent predictor of poor outcome. And decreased level of HB or anemia can cause tissue hypoxia, thus causing delayed wound healing and affecting the postoperative outcome.
So, how will you optimize these patients?
First of all, is it worth optimizing? Is it a modifiable or a non-modifiable risk factor?
Yes, madam, it is a modifiable risk factors. So we can optimize anemia by oral or parenteral administration of iron, folate, and vitamin B12 supplements. And if the patient is undergoing neoadjuvant chemotherapy, we have ample enough time to optimize. And blood transfusion can be considered if there is bleeding and patient is symptomatic.
What is the significance of doing serum albumin estimation in these patients?
Serum albumin as well as prothrombin time usually reflect the synthetic function of the liver. So a serum albumin level which is less than 3.5 grams per liter, it indicates a chronic liver disease or a hepatocellular dysfunction. So from a surgical point of view, it increases the surgical risk and a poorer overall prognosis because there may be delayed wound healing and increased risk of postoperative infections. But from our point of view, it alters the drug pharmacokinetics as the free fraction of protein-bound drugs increases. So we should be careful while giving the anesthetic drugs and should give in a reduced dose. And also, this reduction in the serum albumin may result in causing edema as well as ascites. And this can complicate with our fluid management, particularly during the intraoperative period. And also, serum albumin, the prepared score serum albumin gives a score of 5. So it is of very important significance, and hence preoperatively the correction of serum albumin is very essential from the fact that 5 points is given to serum albumin.
What about the CTP score? Does that take serum albumin into consideration? The child.
Yes, ma'am. Serum albumin is taken into consideration.
Are you aware of the cutoff, the range for ABC for serum albumin?
2.73.
Okay.
Since you're talking so much of serum albumin, is it a reliable indicator of liver function? What are, is it okay? And what are the alternative parameters that you will do to improve your assessment accuracy?
Madam, because hypoalbuminemia is also seen in other conditions like renal losing nephrotic syndrome, in malignancy and malnutrition. So we can consider pre-albumin level or it is transthyretin level because it is a more sensitive indicator of acute liver injury because it is having a half-life of 2 to 3 days, whereas albumin have a half-life of 21 days. But both albumin and pre-albumin is a negative acute phase reactant. It decreased in malnutrition and infection. In that case, we can consider a CRP by prealbumin ratio. A high CRP by low prealbumin ratio suggests inflammation and malnutrition.
So if both are low, CRP, prealbumin low,
we can.
It will be malnutrition.
Yes,
Okay. See, in obstructive jaundice, you can get ascites. And what is the cause of ascites? It may be due to either low albumin or it may be due to the malignancy per se. And how will you differentiate?
Differentiate the ascites, we can use the SAG value. SAG is serum albumin ascitic gradient. And it helps us to classify the portal hypertension, classify ascites based on the portal hypertension. So SAG value can be high, which is more than 1.1. And in patients with obstructive jaundice and with a high SAG value, it indicates it may be due to secondary biliary cirrhosis. And if the SAG value is less than 1.1, it indicates that mostly the ascites has occurred due to malignancy.
So why are you worried? Why do you want to know whether it is cirrhosis or malignancy? Whatever it is, how does it matter to you?
A high SAG value indicates that the biliary cirrhosis has taken place. That means the cirrhosis of the liver has taken place and the disease has become severe. So we should also anticipate secondary end organ damage in the kidney, heart, and also there may be impaired liver function. So that is a clinical significance. And in malignancy, usually malignancy may be associated with cachexia and also grease bleeding in these patients. So SAG values are importance.
Now, what is the usefulness of a preoperative CT as far as an anesthetist is concerned? Surgeon usually to delineate the surgical site or to understand the vascularity, but of what significance is it to us as anesthetist?
So, in a pre-op CT, evaluating for any tumor abutment or vessel invasion help us in anticipating intraoperative and postoperative bleeding. And it can be also used to identify any antral or duodenal dilation, which is suggestive of obstruction, and we can use RSI for induction. And as Anup already mentioned, it can also use to assess sarcopenia by looking the psoas muscle density at the level of L3 vertebra.
So you mentioned gastric dilatation is due to obstruction. Can anything else cause this kind of dilatation?
Celiac plexus injury can cause.
Very good. Because of gastroparesis, right? So if the tumor invades there, it can cause gastroparesis, and even that's relevant to us because you want to consider RSI. Good. So we're going to our next question. And this time, it's again a match the following. And more than one answer may be relevant. On the left, we have the 4 types of bilirubin: unconjugated, bound and free, and conjugated, free and bound. On the right, we have their practical implications. Which one has a long half-life? Which one is increased in hepatocellular or obstructive jaundice? Which one causes CNS toxicity? And which one is measured indirectly? More than one answer may be relevant. Please type in your answers in the chat box. Just moving a bit. Do we have answers or should we wait?
Ma'am, not yet. We'll wait for 10 more seconds, ma'am. Maybe 10, 15 seconds. Till.
The speed has gone down.
And Dr. Preeti has replied A4, B3, C2, and D1. 4, 3, 2, 1, ma'am.
Okay, well, more than one answer may be correct in this kind of thing. Please note, more than one answer may be correct. Shall we move?
Dr. Avni has replied 4, 3, 2, 1. Dr. Ashima also. Dr. Ajay has told B for 3 and 4. A4, C2, and D1. Dr. Kavya, Dr. Jasleen, Dr. Kiranjit, 4, 3, 2, 1.
I'm happy I finally found a question where everybody doesn't get a right answer. So the answers here are so unconjugated bilirubin, whether they are free or bound, they are measured indirectly because they don't combine quickly with the diazo reagent. So the total bilirubin is then measured and it's the direct bilirubin is subtracted from that. So both are called indirect bilirubins. Unconjugated free is lipid soluble. It can cross the blood-brain barrier because it's smaller. And when levels are very high or the blood-brain barrier is immature or damaged, immature like in neonates, it can cause kernicterus. And high unconjugated is what is responsible for CNS toxicity. It can inhibit with the neurotransmitter function in the brain. High levels of conjugated free are seen in hepatocellular or obstructive jaundice. We are all aware of that. When we have prolonged obstructive jaundice, conjugated bilirubin can bind to circulating albumin, and then it's called delta bilirubin. And this is important because it's bound to albumin, it cannot be excreted in the kidney. And second, it will be around in the circulation until the albumin is metabolized, which means even after you release the obstruction, the bilirubin levels may still be high. So the sclera may still be yellow despite the urine being clear. So we need to be, it's an interesting point to be aware of. We'll move on to risk stratification now.
Yeah. You've taken the history, we have discussed about the pathophysiology, and we have investigated the patient. Now, with the evaluation, can you tell me about the risk assessment of this patient? Anup?
Madam, my patient is belongs to the ASA class 3 because of the presence of malignancy with features of cachexia. Also, her child box score is class A, and on evaluation of cardiac status, RCRI score is 1. So the risk of major adverse cardiac events occurring is around 0.9%. And we have all these take into account only the anesthetic aspect of risk assessment. So now taking into account the surgical aspects, recently developed risk stratification scores are present, such as POSM, POSM, SORT, NASQ. So these use physiological, and in our institution, our surgeons mainly use the prepare score for pancreatic dissection, and it consists of various physiological parameters such as albumin level, whether it is an elective surgery or the type of the surgery, whether the pathology is of pancreatic origin, heart rate, systolic pressure, hemoglobin levels, and ASA score. And the prepare score helps us in assessing the risk level for developing major complications. So, as mentioned in the slide in a value less than 6 is low risk, intermediate is 6 to 9, and more than 9 is high risk.
Your patient comes in which risk?
Madam, in my patient, she belongs to an intermediate risk for developing major complications with a prepare score of 9.
So now we move on to the next question. And this is also regarding risk stratification. The first statement, these are both true-false statements. The first statement says a low anaerobic threshold, that is less than 11 mils per kg per minute on cardiopulmonary exercise testing, predicts a high postoperative morbidity. And the second statement says the CTP score is reliable to estimate the severity of liver damage in severe obstructive jaundice. True, false? Please enter your answers in the chat box. Any answers, Dr. Priyaksha?
Ma'am, Dr. Preeti has said both statements are true. Dr. Kavya has said first statement is true and the second statement is false. Dr. Sneha and Dr. Kiranjeet, Dr. Mahalakshmi, Dr. Anisha, Dr. Menognia, Dr. Vismaya have all said the first statement is true, the second statement is false.
Okay, Shri, we'll move on. So because they're right, the first statement is true because this we know we discussed in detail the effect of this pathology on the heart. So the CPET testing is indicated if you have a high risk patient undergoing this kind of a procedure. And when we come to the second statement, we need to remember that the CTP score was designed and validated for patients with CLD and cirrhosis. So it can actually overestimate the severity of liver damage and obstruction because here the serum bilirubin levels are very high despite the fact that the underlying liver cells may not be that badly damaged. So we need to keep this in mind when we deal with patients with obstruction. It may not really, it might really overestimate the severity of the problem.
Now we come to the next session, that is optimizing these patients. Now, can one of you tell me what is prehabilitation and how will you optimize this patient?
Rehabilitation is actually a proactive healthcare intervention before a medical or surgical procedure to enhances patient's medical and mental status, to reduces the postoperative complication and thus enhancing the recovery. So rehabilitation mainly exercise program to increase the aerobic capacity and respiratory physiotherapy to reduce the pulmonary complication and reducing the pulmonary risk. And optimization mainly aims at correction of anemia, nutritional deficits, glycemic control, smoking and alcohol cessation, correction of coagulopathy, and psychological support and management of biliary obstruction.
Okay, next. Now, if your patient has some coagulation abnormalities, how would you correct it?
To correct the preoperative coagulopathy, vitamin K supplementation at a dose of 10 mg IV OD for a period of 3 days prior to the surgery can be given. And if the INR value is still high, that is more than 1.5, we can transfuse fresh frozen plasma at a rate of 10 to 15 ml per kilogram until the INR value becomes less than 1. So overall, our target INR should be less than 1.5 prior to the procedure.
Now, Anjali, you tell me, we have discussed about anemia, nutrition, and about coagulation. Now, tell me, if your patient has some form of biliary obstruction, what is your mode of treatment?
So biliary drainage is usually done by endoscopic pancreatic cholangiography or percutaneous transhepatic cholangiography.
So do you do it for all patients? Is it indicated?
No, madam, it is done on a case-by-case basis by weighing the risk versus benefits. It is usually done in patients with features of ascending cholangitis, severe hyperbilirubinemia, and having a waiting period of more than 10 to 40 days.
Okay, so what is the risk? What is this is a benefit? Why should there be a risk in draining the obstruction?
A stinged in situ are a predisposing factor for ascending cholangitis and this postoperative infection and sepsis. So antibiotic prophylaxis has to be considered in these patients.
Okay. So we are coming to our next question. And again, this is a match the following, and this is with about pharmacokinetics. On the left, we have the pharmacokinetic changes, and on the right, we have the drug. Please match the appropriate change to the drug. And again, here, more than one answer might match. Are there any answers, Dr. Priyanshi?
Anjali to speak louder.
I will give them 10-15 minutes now. 10-15 seconds now, just.
What's the next question?
No answers?
No answers till now, ma'am.
I thought this was the easiest one. Okay, maybe they're all asleep
Ma'am,
already.
there are some answers, ma'am. Dr. Kumar sir and Dr. Sneha, Dr. Preeti, and Dr. Spurti, ma'am. 4, 3, 2, 1, ma'am.
Okay, let me see.
And Dr. Priyanka has said 4, 1, 2, 3.
Okay. So
And
we'll go on with the answers.
Yes,
These
ma'am.
patients are more sensitive to both opiates and sevoflurane. So this opiate sensitivity is probably because of the increased circulating enkephalin. So we need to reduce the dose of opiates by almost 50% here. Recovery from sevoflurane is also delayed, probably because of the obstruction. And the MAC value has to be reduced intra-op because, again, they're more sensitive. We all know this. Relaxant of choice is cisatrac because of the Hoffman's and atracurium because of the Hoffman's degradation. And because vecuronium and rocuronium are metabolized in the liver, it's not a good idea unless you have sugammadex. So we'll now move on to the clinical, the anesthesia per se. There's a lot of talk about IRAS protocol. And Anup, can you tell me something about the strong recommendations in IRAS for pancreatic surgery, please?
IRAS is enhanced recovery after surgery. Firstly, it recommends a multidisciplinary approach. It includes preoperative strategy, intraoperative, as well as postoperative strategies. And in preoperative strategies, absolute alcohol and smoking cessation for a minimum period of 4 weeks, nutrition optimization for a minimum period of 4 weeks, vitamin K prophylaxis at least 3 days prior to the procedure, low molecular weight heparin prophylaxis, avoid mechanical bowel pressure, allow clear fluids up to 2 hours prior to the procedure. Then overnight we can clearly hydrate the patient with IV crystalloids. These mainly include the pre-operative strategies. Coming to the intraoperative strategies, we can use a combined general anesthesia with thoracic epidural. We use a protective lung ventilation in these patients and a goal-directed fluid therapy for maintaining hemodynamic stability, maintenance of normothermia, glycemic control, restrictive blood transfusion strategies, and also timely administration of antibiotic prophylaxis. All these factors contribute to the intraoperative strategies. And coming to postoperatively, we need vigilant monitoring to prevent as well as detect any early complications. Multimodal analgesia is very important, probably epidural. Chest physiotherapy as well as deep breathing exercise can be initiated. We should continue thromboprophylaxis in the postoperative period. Maintain the glycemic control. Importantly, initiate early enteral feeding at least within the 12 hours after the surgery and promote early ambulation, ideally on the first day of postoperative.
It sounds like a lot of hard work. And after the end of this, I've lost track of what he said for pre-op. Anjali, can you just remind us again, what did he say about pre-op fluid and fasting guidelines?
Because of the pathophysiological effect of cardiac system, there is a decreased effective circulatory flow. So these patients are prone for intraoperative hypertension. So maintaining normal volume preoperative and perioperative is very crucial in this patient. So we can consider isotonic crystalloids via IV overnight, and clear fluids can be allowed up to 2 hours prior to surgery. There is no contraindication like gastric outlet obstruction or autonomic diabetes mellitus patient. And we can also give preoperative carbohydrate free. The patient is not diabetic. This can decreases the insulin resistance and enhances the recovery.
So Anjali, you said something about gastric outlet obstruction. How will you suspect your patient has this problem from your history?
From the history, features of vomiting, early satiety, etc., suggestive of gastric outlet obstruction,
etc. Okay. Anup, can you tell me about your pre-medication plan for this patient?
For this patient, I will give lorazepam 2 mg body prior to on the day prior to the surgery. Also, proton pump inhibitors like pantoprazole can be, and ideally thromboprophylaxis with low molecular weight heparin or fractionated heparin should be given at risk of venous thromboembolics.
So you mentioned ERAS, right? So does ERAS recommend lorazepam sedation for these patients?
In elderly patients, ideally they recommend to avoid benzodiazepines and sedations is ideally to be avoided.
You're happy to give your patient lorazepam? Not sure that. Okay. Anjali, what are your anesthetic goals here?
My primary objective will be preserving the organ function and decreasing the surgical stress, madam. And I further avoid the insult to the liver by maintaining the hepatic oxygenation, preserving the renal function, maintaining normothermia throughout, maintaining normovolemia, postoperative hypotension is prevented by judicious fluid and vasopressor administration. And I'll also consider fluid restriction in the reconstruction state to avoid the anastomotic and enhancing.
Okay. So this slide is about the Whipple's procedure, and she said something about resection stage and avoiding excessive fluids there. What is your preferred anesthetic approach for this procedure? And why do you prefer that?
I would go for a combination of general anesthesia with mid-thoracic ideally epidural block of T5 to T9 level. The key benefits include epidural, because of a combination with epidural, it reduces the need for high doses of general anesthetic agents, thereby maintaining a better intraoperative hemodynamic stability. And coming to postoperative, they are effective in controlling pain and reduces the risk of deep vein thrombosis, and also helps in early gut recovery and mobilization of the patient. So they reduces the complication and improves the outcome in patients under.
So Anjali, this slide says that the pain score is high. What is the pain score normally like, and why is it high?
The pain score is usually more than 7 in patients undergoing surgery, because the excision is an
yes
patients, which is a subcostal incision.
Okay. He said he wants to give an epidural. Is epidural always a good idea? Are there any drawbacks to an epidural?
It can cause hypotension, madam. So we need vasopressor support. And in active
hypotension every time, or only with certain kinds of drugs?
Local anesthetics can cause. Local anesthetics in the epidural are more prone for causing intraoperative hypotension. So in that case, we can consider
you can use low concentration local anesthetic. You may be able to use it safely, but the regular anesthetic concentrations may not be so safe. Okay, yeah. Then any other problems?
Coagulopathy, madam. Active coagulopathy.
Okay, post-op, can it hamper in the patient mobility?
Yes, madam. Can cause delayed dissection.
Sometimes, if there's some motor block or paresthesia, it can impact. You need to be aware of that. Okay. So, Anup, you have a big question. How will you induce your patients? What is your induction strategy here? Your detailed plan of inducing this difficult patient. So you need to put together whatever you have discussed and how you are taking those factors into account and keeping your patient safe.
After checking my workstation and airway, I would ideally ensure a good IV access and to give isotonic, and I would prefer to give a 500 ml pause to prevent for any exaggerated hypotension which can occur during the induction phase. And also a vasopressor is kept ready in view of the anticipated hypotension in these patients. Then I would look for Then I would secure an arterial line under local anesthesia, and a baseline ABG would be sent to assess the acid-base balance, to detect for any electrolyte imbalances and to levels. Also, under ultrasound guidance, I will look for vena cava collapsibility index, which gives us a measure of the volume status in these patients. And after that, I will connect my pre-induction models such as ECG, non-invasive blood pressure, pulse oximetry, capnography, and temperature. Then
Connect now.
make sure that it is available.
Okay.
Then I would position my patient for the epidural. After placing an epidural at the thoracic level, I would give 3 mg morphine via epidural.
Okay.
Then, after giving the antibiotic prophylaxis, I would after adequate pre-oxygenation of the patient, I would use a rapid sequence induction in my patient because of the earlier discussed features and symptoms of early obstruction, GI obstruction, such as early satiety, nausea, and vomiting. So, after giving a dose of fentanyl, and I would also do a suction aspiration, giving a dose of fentanyl 60 microgram, propofol 80 milligram IV, and I would use procuronium for as a muscle relaxant for induction of this patient. After securing the airway, an endotracheal tube of size 7, and checking its position, then I would connect to my ventilator. I would connect my patient to the ventilator and would start on low tidal volume of 6 to 8 ml and with a bead. Then I would secure an central line. Central line is also secured, and I would connect my vasopressor to the central line and make sure an indwelling urine catheter is also present because urinary monitoring is also very essential in this patient. So after positioning the patient, my positioning of the patient includes with the arms spread out, and after positioning the pressure points adequately, I would also add post-induction monitors for intraoperative monitoring, which include dynamic parameters such as stroke volume variation, pulse pressure variation, CVP trends can be, and urine output can be more. And serial ABG can be done as indicated. Most importantly, neuromuscular monitor should be attached, and it helps us in titrating the doses of the muscle relaxant, and also random blood glucose monitoring should be done. And in case of severe bleeding or suspected coagulopathy, we can use a thromboelastogram as indicated by patient, and always maintain normothermia intraoperative.
Very good. Very good. Anjali, now we'll go back to fluids. You told me about pre-op fluids, right? What is your intra-op fluid strategy?
Maintaining normal volume is crucial in these patients. The isotonic crystallites are the fluid of choice in these patients, and colloids can be considered if the patient is especially albumin, if the patient is hypoalbumic and also volume expansion is required. So wall-directed therapy is preferred, and we may consider a fluid restriction in the reconstructive phase to avoid the anastomotic leak.
Anoop, do you want to tell us what is this goal-directed hemodynamic therapy? Can you tell us a little more about it?
Goal-directed hemodynamic therapy is a perioperative strategy, and main aim is to maintain the tissue perfusion by tailoring or by adjusting the fluid as well as the pharmacological interventions so that individual hemodynamic targets are achieved. And the main components include rational use of fluids, inotropes, vasopressors, and red blood cell transfusion as per the physiological needs of the patient. Also, dynamic monitoring parameters such as stroke volume variation, pulse pressure variation, or a transesophageal echo can be used to assess the flow-guided responses.
So, Anjali, what are the common problems you have in these patients?
Intraoperative hypotension is the major problem anticipated in this case, madam.
How will you manage and troubleshoot the problem?
The sepsis can also cause intraoperative hypotension. So maintaining normal volume in the preoperative phase itself, even before the precipitating factors, is mandatory. So direct use of vasopressors to maintain the pressure, use of low dose of the induction agents, opioids, and even in epidural, low doses of local anesthetics or morphine alone at the dose of 3 mg during the intraoperative period, and considering local anesthesia administration during the postoperative period. And while giving GA, we have to reduce the we have to give inhalational agents in a low in alveolar concentration. And as I mentioned, sepsis can also cause intraoperative hypertension. So antibiotic prophylaxis has to be considered. Maintain normothermia. And during the surgery, especially during the resection phase, the bleeding can also affect intraoperative hypotension, and also kinking of the major vessels during surgical manipulation, especially like Porcho's procedure, can decreases the venous return and cause hypotension. And insensible fluid flows can cause hypotension in later stages.
Okay. What other problem can you encounter? So basically, Anjali, you were telling us the cause of hypertension will depend on the timing it occurs and whether any anesthetic drug was given around that time, right? Blood loss, timing of the problem, and the possibility of sepsis should be considered actively. And Anup, is there any other problem you commonly encounter in TROP in these patients? If the BP was...
If the mean arterial pressure falls below 65 mmHg, we can develop intraoperative oliguria.
Oh, good. So how do you troubleshoot this? What will you do if your patient's urine output is less?
Firstly, we have to check for the hemodynamic parameters of the patient, such as the mean arterial pressure, central venous pressure trend, or if you are using dynamic parameters, then check for that. And review the fluid balance and assess if adequate volume resuscitation has been done. Check for any ongoing bleeding and blood loss. So, firstly, we have to assess the situation, and this can be done by above action. And coming to the management of this oliguria, firstly, we should maintain a mean arterial pressure more than 65 millimeters of mercury. Adequate fluids via goal-directed therapy to optimize the cardiac output should be given. And consider the usage of vasopressors if hypotension still persists despite adequate filling and fluid resuscitation. Maintain a urine output than 0.5 ml per kilogram per hour. The use of mannitol is controversial, and even if we are using it, make sure that we use it with combination with adequate fluid administration.
And usually it's given in the early stages, not intra. Okay. Anjali, now suppose your surgeon was excellent, you are the excellent anesthetist and everything went well. Would you consider extubating your patient?
I'll consider extubation if the intraoperative period is uneventful and postoperatively the patient is hemodynamically stable, requiring no inotropic vasopressor supports, and patient is normothermic and ABGs are within then I'll consider giving reversal and watch for a TOF ratio of more than 0.9.
What will you use for reversal here? What will you use for reversal?
As we have given chronium as part of RSI, I will consider giving Sugamadex.
Okay.
And after adequate reversal of the muscular blockade, I'll check for if the patient is maintaining adequate tidal volume, respiratory rate 12 to 20 and no signs of dyspnea or tracheal duct, then I'll consider extubation. And as this patient is of intermediate risk for surgery as per the prepared score, I'll consider shifting the patient to ICU for further monitoring and optimization.
Okay, Anup, what will you do in the ICU? How will you hand over and how will you take care of her in the ICU?
As mentioned, this patient requires an ICU care. So we should continue the intraoperative postoperative care also. So ICU care with continuous hemodynamic and respiratory monitoring made sure of. And then we should multimodal analgesia is very important. It can be given either by epidural, by patient-controlled analgesia, NSAIDs and adjuncts. We can give when we are giving opioid sparing and analgesia is usually preferred, and we can use regional blocks such as transverse abdominis block or rectospinal. And then deep vein thrombosis prophylaxis is very important for these patients, especially with high risk and in malignancy. And it is usually advised to continue the postoperative DVT prophylaxis even up to 4 weeks post the procedure because of increased risk of DVT in malignancy and in high-risk patients. So DVT prophylaxis can be done either via pharmacological measures such as low molecular weight apparent, fractionated apparent, or by mechanically using pneumatic compression devices. And adequate for infection control, we have to give antibiotics as per the need of the patient and maintain, start the patient on early nutrition, initiate early enteral feeding as early as within 6 hours, and encourage early mobilization starting on postoperative day 1.
Did you mention incentive spirometry or did I miss it?
Yes, madam. We should make sure also give incentive spirometry and deep breathing exercises in these patients to improve the ventilation.
Okay, good job. Thank you. Now we come to our last question here. This is again match the following to match the perioperative considerations with the appropriate interventions. On the left, we have immunomodulation, post-op ileus, opioid sparing intervention, and anastomotic leak. On the right, we have fluid overload, blood transfusion, intra-op lignocaine IV, and intra-op opiate. And again, here more than one answer may be correct. Kindly type your answers into the chat box. Shall we wait, Dr. Priyakshi, or?
Ma'am, we are getting in some answers. Dr. Preeti has typed 1B, 2D, 3C, and 4A. Ma'am, Dr. Swapnil and Dr. Sneha have replied B, D, C, A, just like Dr. Preeti, ma'am. Dr. Khyati, Dr. Ajay, and Dr. Kiranjeet. Dr. Usha Kumari also, ma'am, B, D, C, A.
Thank you all for your active participation. I'll just go through the answers again. So immunomodulation is a problem we have to expect with both blood transfusion and intra-op opiates. With blood transfusion, they call it transfusion-related immunomodulation, and intra-op opiates too. The concern is of cancer recurrence. So we advise not to use too much of these agents in malignancy. Post-op ileus again is a problem with both opiates and fluid overload. So as anesthetists, we can make a difference to the post-operative outcome if we are mindful of our fluid and the intra-op opiate use. So there's a role for opiate sparing interventions, particularly intra-op intravenous lignocaine. And as Anjali mentioned quite frequently, anastomotic leak is associated with fluid overload. Again, we can help by reducing the fluid administration, particularly during the resection phase. Thank you, and we are open for questions now.
Ma'am, there are a few questions from the audience, ma'am.
Very well done.
Ma'am, Dr. Kirtana has asked, how is ASA scoring done in malignancy? is it different from usual scoring?
Anup wants to take the question.
ASA scoring in malignancy. If the patient malignancy alone does not indicate that the patient belongs to a higher ASA grade. If the patient is asymptomatic malignancy or without any systemic involvement, then the patient can be classified in ASA 2. And in our case, our patient is features of malignancy with features of cachexia. And so if systemic involvement is present, then the patient falls into ASA 3.
Thank you, Anup.
Ma'am, the next question, ma'am, Dr. Anu has asked the role of mannitol and Lasix in the intra-op management.
Anjali, you please answer.
Actually, the use of mannitol is controversial, madam. Studies have shown there is no additional effect of mannitol intraoperatively. Earlier, we used to give mannitol for its diuretic effect, but because of the pathophysiological effect on CNS and the there is a decrease in the central blood volume. So, giving mannitol can cause diuresis and further of this volume and hypertension.
Ma'am, Dr. Aarti has asked if you can explain about the pre-op gut preparation.
Pre-op gut preparation means supplementing nutrition, correction of coagulation, and mainly aim at preventing the bacterial translocation and thus the infection. So we have to consider antibiotic prophylaxis. Lactulose can be administered at a dose of 30 ml 6 hourly for 3 days. And
You skip the last dose and then avoid the last dose. 12 hours before.
12 hours prior to surgery.
You skip that last dose of lactulose.
Ma'am, Dr. Anjali has asked if we can more about the pancreatic enzyme therapy, ma'am.
What, Anup? Anup is smiling. You want to take that?
Pancreatic, madam. In obstructive jaundice, usually the exocrine function of the pancreas is usually affected. So,
how will you know whether the exocrine function is affected?
From the clay colored stools and bulky stools, steatoria usually indicate pancreatic exocrine function deficiency. So, we may have to supplement pancreatic.
Ma'am, Dr. Ajay has asked role of wound infiltration with continuous local anesthetic.
Anjali?
A multiple port catheter is usually used for this wound infiltration. It is usually done by the surgeon before closing the incision. So a continuous administration of local anesthetics can be done even in the postoperative period. So thus reducing the pain in this patient.
Is it over?
Ma'am, 2 more questions. Ma'am, Dr. Ashima has asked if why do we use rapid sequence intubation for a patient with obstructive jaundice? Why do we prefer RSI in obstructive jaundice?
From the history itself, patient has features of early obstruction, features of GI obstruction such as early satiety and gastroparesis may occur, and also these features along with from our imaging modalities we can detect whether there is an obstruction causing a stomach, a dilatation of the stomach. So all these features to prevent the risk of aspiration of patient, we prefer to use a rapid sequence induction.
In this patient, it is not always necessary, but in this patient, because you saw features of obstruction, you did. If your patient does not have features of obstruction, you can do a regular intubation. Okay.
Ma'am, Dr. Preeti has asked how to improve the nutritional status of a patient with low BMI, as carcinoma is an urgent surgery, and for how much time we can optimize and defer the surgery for build-up.
Anjali?
The patient is undergoing neoadjuvant chemotherapy. We get ample enough time to optimize the nutritional status because usually the patient act for a period of 2 to 6 weeks, and we usually consider administrating low fat, high carb, high protein diet for nutritional supplementation.
Should supplement in protein requirement at a rate of 1.1 gram per day may be necessary in these patients. And for nutritional supplements can be access for sarcopenia. Correct.
I think more can be added to this question actually. Uh, I'm actually getting very impressed that the PGs are taking the Viva head on, whether a PG student is asking the question or a consultant is asking the question in this forum or platform. So they are giving examination not to the two internal and two external, they are giving examination to almost 70 plus externals. So I'm really impressed first time that they are in our class, the PGs are taking the questions head on, and 90% of their questions and answers are almost up to the mark. Even for these patients, I can just say that you cannot say by all the patients you have to build up. It's on an individual basis, type of carcinoma, degree of invasion of the carcinoma, time given to you for optimization. It's again individual patient, which type of carcinoma you really want to optimize or not, or whether you go for a surgery or you can optimize later in the ICU, something like that. So it's a very individual and customized approach for such different type of carcinomas. So that's the answer to this part also. But I'm really impressed. Madam, I think that's why in the beginning I was not wrong when I said the Jubilee Mission Hospital, why it is called one of the best hospitals. So you can see very well from the answers given by the PG students and that to second year, and that too on a national platform with so many questions fired at them. This is a serious thing, and I'm not just joking around or just making them lighter feel. This will instill a confidence among all the PGs in India that these are the ways that the PGs can face any examination. Indian PGs are better than any PGs of the globe. So these classes are viewed by the international PGs also, but from different parts of the different. When you go to the YouTube, you will get addresses of different PGs from different hospitals and colleges of different continents. So this is what I like today. They are taking every question head on. If they are not taking, madam is directing to them. Take head on. Rather than madam helping you, you are doing it yourself. I am really impressed today. Honestly.
Thank you, sir.
Next question is there, Priyakshi.
So one last question is there, sir. Role of tab block in post-op analgesia, sir. That's all.
Regional, this regional anesthetic can be used as a part of a multimodal anesthesia. So it can provide prolonged anesthesia post-operatively, and thereby we can also reduce the usage of the other drugs for pain management.
Definitely tab block has a role because in the first 24 to 48 hours, that's the most inflammatory period where you can get a maximum pain, I think, in and around the region. So tab block almost takes out around 70 to 80% of the analgesic effect provided the block. But you have to, as I see, Arvind said, it's a multimodal approach. You have to have the, supplement with the systemic or other analgesics. So to have a complete effect, because these patients may not be able to tolerate the pain associated with such a massive surgery. But tab block does have a good effect on these patients.
Thank you.
Thank you, ma'am.
Yeah.
somebody asked about the role of albumin. I think that is a very basic PC question. And I think that's again taking the vibe of our PG students. What is the role of albumin apart from maintaining the oncotic pressure? You can delineate at least 50 roles of albumin in the body. So that's a very simple physiology. Do you want to answer that, Anjali or Arvind? You want to answer that?
Role of
Alvin.
okay. Sure.
Oncotic.
There is a medicinal body
Voice is not audible.
balance and algorithm so uh, shows malnutrition in this patient.
Drug
They act as a
metabolism.
buffer.
Drugs.
See, suddenly is out of the blue question. I can a counter question to that other person also who asked this question, if you ask me. Do you remember any more? What is the role of albumin actually in a patient of cachexia with the cancer patients in these type of surgeries? I think the more for first and foremost is not oncotic pressure that is going to be maintained with the liver dysfunction. It is obvious that albumin deficiency is there. What about the drug dosages? How are you going to reduce the things? How are you going to titrate the protein binding of the drugs? The pharmacokinetics, the pharmacodynamics. You have to measure those things. I think the anesthesiologist who makes the balances in these type of situation, that's the best way. It's a perioperative part of a perioperative medicine with the comorbidities. So you decide the dosages. That dosages may not affect your renal functions, your hepatic function later on. So many toxicity of the drugs. So many things are going to be happening with albumin.
Acute
It's a
phase
main
reaction.
protein of the body.
It's also an acute phase reaction.
So anyway, before moving forward, just wait. I will like to at least. This is a wonderful class. I really enjoyed it. Yeah. So just wait, sir. Usha madam, my screen visible?
No. Yeah, okay, yeah. Yes, sir.
Yeah,
Yes.
yeah. So first of all, thanks to the captain of the ship, Dr. Mariam Koshi Thomas, madam, being the professor and head. It's a responsibility. All the responsibility lied upon you as a professor and head. So thank you for preparing your team in such a good manner, and it's a wonderful class. And the equal captain, Dr. Usha, madam. I think you proved me right. Why the Jubilee Hospital, Mission Hospital, is considered one of the best hospital in Thrissur. So that was evident from the spontaneous answering and without any help from the teachers, the students were answering those questions. So you know very well how does they prepare their subjects. Thank you, madam, for that. And Anjali, Arvind, and Anup. So you did a wonderful job. So both
Thank you,
of
sir.
you, Anup, your membership form will be approved. Don't worry. But you already filled a life member, so I think you have already passed your MD examination. So it's obvious that you have already passed today. So, but still, I will not make you life member. You will be associate life member only. So thank you very much to both of you. Really impressed today.
Thank you.
Thank you,
Yeah,
sir.
yeah. And Priyakshi, you took in a different manner today. You were taking the names of everyone who was, asking the answers. That was a different way of presenting as a screen coordinator. That reflected your confidence. So you are going to be a very good faculty in the near future. So that's thank you, Priyakshi, for taking the all the screen coordination along with Dr. Ayushi. Ayushi, you were also good, no doubt about that, and you did wonderful job. Thank you very much for being the screen coordinators for this class. And always thanks to Dr. Madhuri Madam, Dr. Nishan, Dr. Ridhiman, because they are always there as a team. And we have been carrying this flag of ISA national classes with the discussion of the last 3 years. And today, I can say on a, on a record that this is one of the best classes I have seen over the last 3 years, and it will be recorded on the YouTube. It will be played, and I think the way the PGs were answering, that reflects upon the knowledge imbibed, the level of education being imparted to the PGs, the training being imparted to them, the
That
confidence being instilled into them. That's the way the PG education should be in our country. So really proud of, I think, both madam and their entire hospital for having such a postgraduate program where the PGs are having such a good confidence to express neutrally to everyone, whosoever was asking. We never asked who was asking, whether it's a PG student or a senior resident or a consultant, but they were equal to the task. Then did not require any help today. I think Dr. Madam will be agreeing with me. Isn't Dr. Madhuri?
Yes, yes, I fully agree that they answered very well and they finished at the right time and they covered all the important points. That was very nice.
Yeah.
Uh,
Anything to be added further?
yeah, I just wanted to add a bit to the the Whipple's procedure. There was this is for the PJs, okay? So there was a lot of mortality associated with Whipples in the initial days when Whipples was the first three cases of Whipples were reported in 1935. So
yes,
after that, there was a lot of mortality. So basically, the mortality was due to the anastomotic leaks and the type of drains that they used to put. They used to put open drains. Okay. And then later on, so it was almost 25% mortality then. But then slowly they also devised their techniques and now they use the closed suction drains. And they are, of course, the skill of the surgeon matters a lot,
Yeah.
especially if there is an anastomotic leak, then the mortality is going to be there. And the longevity of the surgery, the lesser the skilled and the longer the duration of the surgery, the outcomes are going to be very bad. So everything depends on that. If you have a surgeon who's operating for 12 to 13 hours on Whipples, then definitely your results may not be that good. So I just wanted to add that. And now multidisciplinary communication and the multidisciplinary teamwork and advances in critical care, everything has improved the outcomes after Whipples.
Yeah. So that's a very important point about that anastomotic leak. Because once it starts in the Whipple, I think it's very, very difficult to save the patient. You may re-explore the patient, you may go with a re-exploration surgery, but it's very difficult to prevent the sepsis, prevent the, the hemodynamic parameters. It's become really difficult. So the skill of the surgeon is very, very important because this is such an important surgery. It should not be used as an experimental or by a teaching aid. Rather, it should be in a observational surgery for the residents, maybe for DM residents, sorry, MCH residents or whosoever are there. It should be the most experienced person who is well versed in the surgical skills because it's most of a microsurgery rather. Any microscopic part leaking, any anastomosis leaking, it is going to create a havoc. So
Yes.
definitely the skill of surgeon. Dr. Mohan was asking about the laparoscopically. I think in the laparoscopic era, even Whipple is more accomplished with the hand surgery, with the open surgery, rather with the laparoscopic. Laparoscopic, you may not be able to do the precision with the able precision, whether with the robotic also. What with the good surgical hands, you can give the good results in Whipples. Laparoscopy has a learning curve of a long, long time. And again, what Dr. Madhuri said, the longevity of the surgery is a bad prognostic factor in such surgeries. So it's better to, for such surgeries, the experimentation should be minimal. Whether you want to experiment, you go for some other laparoscopic surgeries where you can learn these steps, maybe from a resection anastomosis pipe. But in these type of surgeries, every step of a surgical skill is going to play a prognostic part of the patients. Anyone can ask any suggestion. We may have 1 or 2 minutes before we switch off.
I think there is one question. Late
Yes.
respiratory complications of Whipple's procedure.
Respiratory complications.
late
One
respiratory.
minute.
Which one?
Late is what? Late complications means same thing, atelectasis, ARDS, pneumonitis, collapse. These are the most common complications after any upper abdominal surgery. है ना?
Yeah, even the laparoscopy, this one, sorry, the what you called incentives parametry. Even that has to be done very carefully, that because the forcible, sometimes what happens, the patient may not be well educated. They may try to sometimes become too much enthusiastic. If the pain is controlled, they may blow up or they may inhale in a very forcible manner that can also disrupt the anastomosis. So it has to be very, very careful. You have to be teaching these patient in a very careful manner how to go about the incentives parametry rather than creating a very positive abdominal pressure or huge, which may be affecting the anastomotic sites also. Anything else left to
No,
be
sir.
discussed or to be given?
Questions? No more questions, sir.
Okay.
Thank you.
So thank you, ma'am, both the ma'ams. Thank you very much. And this class will be available on the YouTube at ISA NHQ, and it will remain there as a part of the ISA, what we call the treasure. So people can go before examination for a long case. When it comes, they can go to the, even during the long case, if they have a mobile with them, they can go to the YouTube and watch what was being asked. You have leaked the question paper today. So was a good thing. So, and we are really thankful to the Jubilee Mission Hospital, Thrissur, for taking such a good class. And thanks to the PGs and screen coordinators and my co-coordinators, Dr. Madhuri, Dr. Nishan, and Dr. Ridhima. So we end up by saying, long live ISA.
Long live